So, interventional procedures are safe if we are comparing with the surgical counterparts. Then it is much safer than the surgical procedures. Say, for example, in an osteoarthritis knee, if we are comparing the TKR versus genicular nerve ablation, the genicular nerve ablations might be 100 times safer. But still, I compared this with safety in an aeroplane and safety in a bus. If you are comparing the accidents in the road transport versus the accidents in the flight, the accidents in the flights are much less than the road. But still, whenever you are entering in the flight, all the safety protocols. In the bus, have you heard it? That okay, this is the way to tighten your seat belt. So nothing like that. So even though it is safer, still we want to be more safe. So same way, interventional procedures are much safer than the other things, but still we need to make it still safer. And for that, we must follow some of the basic guidelines, basic protocols, how to make this completely safe. Nothing is completely safe in medical practice, but still we want to make it as safe as possible. So the safety thing starts from the selection of the patient. Means proper selections, right patient for the right procedure is the beginning. Say for example, you are seeing a patient where the patient is having the MRI shows there is a prolapsed disc. But on clinical examinations you found that the symptoms of the back pain and leg pain are not because of the prolapsed disc. It is because of the sacroiliac joint or facet joint. It might mimic the back pain with the leg pain. Many times this happens. And the study says that MRI, when it was done in asymptomatic individuals, this study, one of the first study which was there conducted in the early 90s when the MRI was very new. So the cases was, or the individuals was who never ever had any back pain and leg pain. And MRI was done in those patients. And what was the findings? Findings was that in those more than 50% was having the prolapsed disc who never ever had any back pain, leg pain, and 28%, I remember this figure still now, 28% was having the large extruded disc who never ever had any back pain. So the question is, should these patients be selected for interventional procedure which is completely asymptomatic? Answer is no. And in fact, we are now conducting a study. It is almost completed, but still there are final adjustment is there for the final submissions in the journal. We conducted this study on the asymptomatic individual with shoulder pain. So who never ever had any shoulder pain. We selected those individuals and we scanned the rotator cuff, particularly supraspinatus. And you know what is the findings? Who never ever had any shoulder pain? The findings was tendinopathy was seen in 35% situations, and tear, asymptomatic tear was found in 15 to 18%, exact figure I don't recall right now. So it's partial tear. Even full thickness tear, not complete tear, full thickness tear was seen in 2% patient individuals. So that means the image is not the final one. Image should be correlated with the clinical findings before taking any decision. So now say for example, as I told you earlier, that suppose a patient with a prolapsed disc where on MRI and the patient was basically symptomatic because of the sacroiliac joint pain and you are selecting this patient for some disc procedure. So what you are doing? You are putting this patient in the risk of having the disc procedure related complications like discitis. Discitis is a very bad complication. So proper selection of the patient is very, very important and your safety starts from there. That means right procedure for the right patient then only you are going to get the good results without minimal complications. So then, what else? Once you have selected the right patient for the right procedure, then you should have some minimal investigations which is in general needed for all the procedures, and some specific investigations before doing some specific interventions. So general investigations what are needed to rule out the contraindications of the interventional procedures. So that means we must know what are the contraindications for the interventional procedures. General contraindications. So what are the contraindications when you cannot do? One is coagulopathy. So if the patient is having any bleeding disorders, or if the patient is on the anticoagulant, particularly anticoagulant which is not aspirin, more than aspirin. So you should be following the same protocols for the regional anesthesia. That aspirin is not contraindicated, but the other more than that, like clopidogrel, warfarin, all these things are contraindicated, and they must be stopped. Or if somebody is having the coagulopathies, then also those are contraindications. So what is one of the very important screening investigations to be done? Proper history, that whether the patient is receiving any anticoagulant, proper history of any disease indicating coagulopathy, and if needed, you have to go for the coagulation profile, particularly for the invasive procedures. Except for the very superficial procedures, most of the other procedures, we must be, suppose you are doing the celiac plexus lock, it is mandatory to go for the coagulation profile, whatever is the history. So the more invasive procedures, the full coagulation profile is needed. Next, uncontrolled diabetes is a contraindication. So you have to check for the blood sugar and the HbA1c. So if not, unless it is very much emergency, you must be controlling the blood sugar at least to a certain limit, and then you should go ahead with the procedure. Then what is another contraindication? If the patient is having any infection, either local infection or systemic infection. If these are there, then these patients, we have to stop the procedures before controlling the infection. So here again, the routine blood, complete blood count, then your ESR, CRP, these parameters should be done. Sometimes we have seen patients where the patient is afebrile, not that symptomatic, maybe just slight malaise, and this patient was found, we found that the total count is raised, 13,000, 14,000, CRP is raised, and after a course of antibiotic, with the help, with the consultation of the medicine doctor to find out, to search for any infection, and then you have to go for that. So these are the general contraindications for the procedures, and all those things should be ruled out. So 3 important contraindications in general for all interventional procedures. There might be specific contraindications for some specific procedures, but these are the general contraindications for everything that must be ruled out. So one is your infection. For that you have to check the blood investigations also, not just the history of fever or something. Second is the uncontrolled diabetes, so you have to check for the blood sugar and all those things. And third one is the coagulopathies. For that you have to take the proper history. Like sometimes patient is taking clopidogrel. This is so common. So you must be stopping the clopidogrel before doing the interventions, and you might be replacing this clopidogrel with aspirin before doing the procedure, because aspirin is not a contraindication. So apart from that, there might be certain specific contraindication for some specific procedures. You have to go for that also and investigate properly before going for the interventions. Next important step for preparing it is your patient's consent. So lack of consent is a contraindication. Unless somebody is giving the consent, you cannot go ahead. So for that, what is very much important is to talk with the patient, take the risk versus benefit ratios, that these are the risk and these are the benefits, and you have to justify why you are going to do that procedure, and listening all, and you have to give the proper information to the patient in terms of percentage, that this is the success rate, if this is successful, these are the things that you are going to get If not, if you're not going for the procedures, then what are the consequences? What are the consequences of the long-term pain? If somebody is suffering from pain for the long term, what are going to happen, like psychological aspects and many other things? You have to give all the information to the patient before taking the consent. So if the patient agrees that understanding the risk versus benefits, then only the patient consent should be asked for. So these are the mandatory before you are planning for any interventional procedures. Then what else? What are the things to be done? Patient should be explained about the procedure, what exactly you are doing. That is a part of the risk versus benefit. And on the day of the procedures, there are certain aspects. What are those? That patient should be coming with nil per mouth for at least some 4 to 6 hours, and some intravenous, most of the times, very peripheral interventions, superficial interventions. You may not have a intravenous line secured, but most of the times we always tell that the patient's intravenous line should be secured, so that in any emergencies you can use that intravenous line to administer any kind of drug. Like what happens, say for example, suddenly somebody is having the sudden fall of blood pressure, and maybe that time you are unable to find out the sudden cardiac arrest. If your cardiac arrest is quite common in our patients here, also have seen very simple procedures, just a little bit of local anesthetic patient, maybe the local anesthetic has gone intravascular and the patient's sudden bradycardia. So unless your intravenous line is secured, in that emergency period, securing an intravenous line and giving the drug, administering the drug might be difficult. So it is always wise to have some intravenous line secured before doing the procedures, except for some very superficial procedures. Even those cases also, intravenous line is a better choice than not to have it. Then all the vital parameters must be monitored. Again, I am telling you, we are giving you the examples that very simple procedures, because we are having the vital parameters monitoring, suddenly we could understand the blood pressure, the pulse rate is falling down, blood pressure is falling down. Unless you are having the basic monitoring, you cannot appreciate that sudden fall of blood pressure or sudden fall of your the bradycardia. You cannot understand it. So the vital parameters must be monitored, particularly the pulse, blood pressure, and the saturation. These are the at least 3 things which must be monitored during the procedures. Procedures must be done not in the OPD setup. All the procedures must be done in an operations theatre setup, and where all the rescue medicines must be available. So in case of any emergencies, just now we were talking that your basic resuscitation medicines, most of you are from the anesthesia, you know what are the resuscitation medicines, starting from the atropine, adrenaline, blood pressure raising drugs, so fluid, many times you have to give the fluid. So all these basic resuscitation things should be there. Apart from that, you must be having at least one basic anesthesia monitor, basic facilities for the intubation and the ventilation. Again, I can give you the one example. In my early days, I was doing some, the blind procedures. Earlier, we used to do the blind procedures a lot. Nowadays, no single procedures are done blindly. Nowadays, each and every procedures are done, even if very superficial, even if peripheral, even then the blind procedures are not recommended. So those are the days where we used to do the blind procedures. So I was doing some, the trigger point injections in the cervical areas, and this patient, somehow the patient, the local anesthetic has gone either intravenous or intrathecal, we really don't know, and suddenly patient becomes unconscious, and there was the saturation was falling down. So we immediately need to ventilate, and we immediately need to, after certain times of ventilation, certain period, even though the patient respiration was not normal and the airway was not very good for the mask ventilation, so we had to intubate for 15-20 minutes. After that, the local anesthetic effect was reduced and ultimately the patient. So if this procedure was done in an OPT based, where this is a very simple procedure, trigger point injection, so simple. So even then, this kind of complications, these are very rare. I am only in my own life, one such incident happened. But still, if one patient die out of your several, million of patient, even then it is a disaster. So no procedure should be taken lightly. Every procedures must be done in a minimum OT setup, where the intubation facilities must be there, where the boils apparatus must be there. Even if you are not having the boils apparatus, earlier you can remember, earlier we didn't have the boils apparatus, very early, but at least we had an ammo bag, we had the facilities for the intubation. So at least you can intubate and you can do the basic ventilation and you can shift the patient to a hospital setup. So the few things which are mandatory for the patient's resuscitation is the anesthesia machine. A suction machine is also very important. Many a time you need to clear the airway and you need a suction machine. So suction machine, anesthesia machine, and your emergency tray where all the drugs, at least the common drugs what is needed for the managing the bradycardia and all those cardiac arrest. So these kind of drugs must be the allergic, anaphylactic reaction. Sometimes even small doses of the test dose of the antibiotic can cause the anaphylaxis. So must be having the adrenaline and all of the drugs ready for. These are rare, but still you must be well prepared because these complications are life-threatening complications. I can give you another example where the caudal epidural was done and patient immediately became unconscious and patient was intubated and ventilated, and unless again this was not done in the OT, the patient is going to die. So these are all the interventional procedures, because local anesthetic, if it goes intravascular, if it goes intrathecal, it can cause disaster. It can cause even the total spinal anesthesia. You know that. So all resuscitation facilities must be there, and then only you can think of doing a procedure. So on the day of the procedure, patient must be nil per mouth for few hours, just like regional anesthesia protocols, and patient intravenous line secured and all the vital parameters monitored. So now whether to give sedation or not, this is at least for me it is a controversy, because I don't use the sedations, but majority books suggest sedation. Sedation is somewhat, it is good that the patient's anxieties are taken care, but in few patients, at least in 5 to 10% patients, you have seen that why I stopped giving sedations. Earlier also I used to follow the protocols and I used to give the conscious sedation. But what happens in 5 to 10% patients, they become incoherent. So they are not obeying the verbal command. You must also, many of you are anesthesiologists, you have also seen sometimes a small dose of midazolam, small dose of the patient are not obeying your verbal commands. So what happens here when you are doing a patient and you need the patient's position to be maintained. If the patient is moving, if the position is not maintained properly, it is very difficult to do the procedures. So that is one of the reasons why the conscious sedation might be sometimes a problematic, because your patient is not obeying your commands, or whatever you are talking, patient is not coordinating with you nicely. Patient should be fully conscious, and any complications, any inadvertent placement of the needle, patient must be noticing and giving you the feedback. That is mandatory, and that is the reason why general anesthesia is never recommended for any interventional pain procedures. Please write it down in a bold word that general anesthesia is not recommended for any of the interventional pain procedures. Why? Because if the patient is conscious, I am giving a very simple example, that you are trying to do a transforaminal epidural, okay, and in the foramen you are having the exiting nerve root. So many times it can happen that when you are entering into the foramen, normally what is the recommendation? You remain in the upper and the outer part of the foramen so that you are not touching the nerve root. But many times this can happen that actually you are touching the nerve root. And what will happen? Patient will be feeling the very severe lancinating pain along the course of the nerve. So if you are just touching it, then patient's feedback is going to prevent further entry and injury. If the patient is unable to give you the feedback, you might be going inside the nerve, you might be injecting the drug inside the nerve, and that might be causing the neural damage. Even the paralysis is possible by neural damage, permanent paralysis. So normally, like in the regional anesthesia, what is recommended? The drug should be given around the nerve, not within the fascicles of the nerve, not within the nerve bundles. Now, if the patient is having the general anesthesia, patient is not going to give you the feedback. Otherwise, as soon as you are touching the nerve, the immediately patient will be telling some lancinating pain, and you are immediately removing it. And that is the reason why you should advance the needle millimeter by millimeter when you are close to the target. So that is one of the very important reasons. So this is just one of the examples. There are many such similar examples where patient's feedback is needed. So general anesthesia is contraindicated. General anesthesia is contraindicated. If the patient is very much anxious, you can give small amount of the anxiolytic drug or sedation. But even taking care, remembering that even very small amount of the sedative drug sometimes, make the patient unable to give the feedback of any needle placement. And that is the reason why what I have seen, that if you are giving the good adequate local anesthetic, particularly the skin, and waiting for at least for 30 seconds, lignocaine onset of action is 30 seconds. So you must be waiting for at least 30 seconds, 1 minute before starting the procedure. Then, majority patients are not complaining anything. Majority patients are well coordinated, obeys your verbal command, and majority interventional procedures can be done very nicely. Even I have seen vertebroplasty. Sometimes it is a painful procedure, but still we can do it very nicely with the local anesthetic only. No need of giving any general anesthesia. So forget about the general anesthesia. Even sedations must be given cautiously, and deep sedation is never recommended. You have to always remember, keeping this in your mind, that patient must be fully awake to give you the feedback of your inadvertent needle placement. So this is one of the very, very important safety aspect. Then you have to do the procedures properly. That depends on the individual procedures what you are doing. Keeping in mind that the procedures more close to the head and neck are more risky. So procedures more peripheral or in the spine, more you are going distal away from the head and neck, you are safe. Like say for example, it's very difficult to land up with the complications with the sacroiliac joint injection. It's very difficult to land up in a complications with the facet joint injection because we are not within the spinal canal. But if you are doing an epidural, when you are entering into the spinal canal, it is key. That is why I always tell the epidural procedures are the most risky procedures. And there are lots of blood vessels are there. Inadvertently you might be injecting into that blood vessels, and there might be infarction of the cord also. Lot of such things has been reported, and what I was telling you just now, I have seen one patient, not in my hand fortunately, but I have seen patient where caudal epidural landed up with the quadriplegia because of the infarction of the cord. So always remember this thing, that the epidural procedures are most dangerous procedures, even more dangerous than discography. Discography might have your long-term complications like discitis, but epidural's immediate complications is a very long list of complications of the immediate complications. Drugs, particular steroid going into the blood vessels, the local anesthetic with preservative, or deposteroid with preservative, it might be going into the arachnoid space, total spinal anesthesia. So all those things, bradycardia, cardiac arrest because of the local anesthetic going into the intravascular space, all these are possible if we are going into the epidural space. So always remember that the procedures which carries more risk needs more supervision during the procedure. That means when you are doing the procedures involving the head and neck, say for example cervical epidural you are doing, say for example gastric ganglion you are doing, so you have to take extra precaution that, always, let me give you another example, and this happened few times in my patients, that when you are doing a gastric ganglion block, so you are very close to your dura. In fact, there is a dural extension which you are puncturing if you are going for the the glycerol injection. Nowadays we don't give glycerol because radiofrequency is much better procedure. Cryo is also a very good procedure. But still, once you are giving the local anesthetic before doing a heat lesion, when you are doing the thermal ablation, you must be giving local anesthetic. For the cryo, you need not. You can go ahead directly. But for the radiofrequency, you need to give some local anesthetic before doing that. And because you are into the dura, so this drug might be going intrathecally, and very small amount because it is very close to your all these respiratory centers and all those things. Apnea, respiratory arrest is one of the complications. And I came across 2-3 such cases. There was no CSF was coming. Before doing the procedure, we have given some local anesthetic just to numb the area, and normally we don't give dye in the gastric ganglia, because if you are giving the dye, your needle tip visibility, exactly where your needle tip is basically obscured. So it is not recommended to give dye when you are doing the procedure. And aspiration, CSF might not be coming, because sometimes what happens, the dural flap works like a valve. So if you are aspirating, so nothing might come, but still your drug might be going into the intrathecal space. This can happen. And what happened, as soon as normally what amount of the local anesthetic is recommended before doing the gastric ganglion block? Something around 0.5 ml only, not more than that. Even 0.5 ml local anesthetic, immediately patient become apneic. Saturation starts falling down. Needle is in place. So you can understand the terrible situation. Anyway, most of the situations, after doing some of the mask ventilations, in all my cases, some mask ventilation itself, patient becomes again the conscious respiration becomes normal, saturation becomes normal. But this can happen. So the more you are close to head and neck, your complications, the severity, magnitude of the complications are much more. So you have to be extra cautious. Like earlier also I used to do that when you are doing this gastric ganglion, you can put a nasal cannula and you can give the low oxygen before when you are doing it, so that if your oxygen saturation is fine, then even if small apnea, you can you will be having some additional time to handle this patient. So that is also one of the safety aspects. So what I want to tell, that more close to the head and neck, the procedures becomes more dangerous, and you need to put more cautions before doing this procedure. And more invasive procedures, like just I was talking about the vertebroplasty, like spinal cord stimulator. More invasive procedures, you are putting thick needle. What is the gauge of the vertebroplasty needle? 11 gauge needle. And more chances of damage. You are injecting bone cement. That bone cement might be going into the intravascular space and landing up with the embolism and death. If you are talking about what are the risk of the vertebroplasty, death is one of the risk, paraplegia is one of the risk. So more invasive the procedures, endoscopic discectomy, more invasive procedure, cutting something. So you might be inadvertently cutting the nerve roots also. So the more invasive is the procedure, more is the risk. So which procedures are more risky procedures? When the procedures are closer to the head and neck, like same epidural, when you are doing the lumbar epidural versus cervical epidural. The lumbar epidural versus cervical epidural is much riskier than the lumbar epidural. Lumbar facet joint versus cervical facet joint. Cervical facet joints are much riskier because you are close to the head and neck, because the blood vessels are directly connecting with the brain. So anything going inside the blood vessels might be going and causing the infarction of some part of the brain or cord. So all the procedures closer to the head and neck are dangerous compared to the periphery or compared to the lower part of the spine. And more invasive is the procedure, more is the risk. So you need to keep extra precautions. Your team, everything is ready for any of the inadvertent or any of the complications. You have to manage, identify and manage the complications as early as possible. So before doing any procedures, you must be having a full knowledge about the anatomical structures nearby, because those are the structures where your needle might be going inadvertently. You must be having the full knowledge of what are the possible complications, and you must be having the full knowledge about diagnosis and management of those complications. So this is, I'm not going to elaborate it because it varies from procedure to procedure. But each procedure, whatever procedures you are doing, you must be always remembering what are my nearby anatomical structures, important structures where my needle might be inadvertently going there and causing the damage. Like say for example, we are planning to go for the splanchnic nerve block or celiac plexus block. What is the important area you have to take extra precaution? Is the foramen. So you might be, needle might be going into the, because foramen is the most dangerous area where the nerve root is coming out. So your alcohol might be going into the foramen and you might be landing up with some paralysis. So same way, whenever you are doing any procedures, just remember what are my nearby structures, where the drug or needle might be going inadvertently and landing up with some complications. So early complications can happen in any hand, even in the expert hand. But what is more important is you must not miss a complication. You must be able to recognize the complications immediately and you have to take appropriate measures. Just now I told you that during doing the gastrin ganglion block, I given the local anesthetic before the radiofrequency and patients landed up with the apnea. So what we have to do? We have to immediately recognize it and immediately we have to take care of it. So what I'm going to tell, that complications can happen even in the expert hand, but early diagnosis and timely management of the complication is more important. And again, what I told earlier also, that try to avoid the complications as much as possible. If you know that what are the complications, you will be able to avoid this much better. And this is also very important, that instead of learning from your own mistake, you learn from your senior's mistake. Wise people learn from senior's mistake, not by their own mistake. So if you are knowing what are these are the complications, this happened earlier, with the seniors, so you must be keeping that in mind and trying to avoid those complications. So these are the complications, these are the timely diagnosis and management. And then finally you are doing the procedures, you must be observing it for some time, at least duration of the local anesthetic actions. So you must be observing that. Some procedures which are more invasive has to be kept for a longer time. Say for example, you are doing a vertebroplasty. You must be keep the patient admitted for at least 6 hours. If you are doing some intra-articular joint injection, you might be not keeping admitted for that long time. You might be keeping it admitted for half an hour. So depending on some procedures, but patient must be observed doing the procedure and immediately discharging, that is not advisable. You must be keeping some time. And normally what we do, after doing the procedures, we keep the patients observed, and during that time we apply the ice. That is one of the very good option for minimizing the procedure related pain, because you have punctured the needle, so there is a pain during the of that procedure, and that is best managed by application of ice. So apply ice for 10-15 minutes and observe that time. Observe if there is any local anesthetic. Sometimes even if you are giving 1% local anesthetic, lignocaine, or 0.5% lignocaine, even then some patients might land up with some motor weakness. So ask the patient to walk, ask the patient if there is any weakness of the legs, if there is any dizziness that might be there because of the intravenous, the drug, intravascular drug, local anesthetic. So you must be asking the patient to walk properly, no weakness, no dizziness, then his patient is ready to discharge. And when you are discharging the patient, again another very important thing is, which might be little late complications, not immediate. Say for example, you have done some spinal procedures and there is some hematoma within the spinal canal. This hematoma may not be symptomatic immediately. This hematoma may be symptomatic only after a few hours. When the hematoma is big enough to compress the spinal canal, then only patient might be symptomatic. So you have to always tell the patient that if you observe some weakness of your legs, if you are unable to pass urine, which is extremely dangerous, which indicates the parasympathetic nerve damage, if you are having any respiratory difficulties, if you are having any the loss of visions, any motor weakness, any numbness which is new, which was not there earlier, immediately report, immediately come to the hospital. So these are the warning signs. Normally these do not happen, majority patients, once you are taking the good care during the procedure. But still you have to tell this to your patients that if you are observing any of these then you immediately notify us. Then another, which is common for any interventional procedure, is the post-procedure infection. Again, these are rare, but still this can happen. Infection, always remember that do not happen during the procedures within the first 48 hours. So sometimes I have seen even the doctor, one of the surgeon also, what happened, we did some shoulder procedure. And on the same day, patient was calling me in the evening. He was a renowned surgeon here, that Dr. Das, I am having terrible pain in my shoulder. What was there? So this can happen sometimes, particularly the tendinopathy. If you are injecting in the tendons, patient might be having that terrible pain. And they are telling, Dr. Das, shall I start antibiotic? You have not given any prophylactic antibiotic. So shall I start it? So what will be your answer? Should you start antibiotic? Because the pain has increased too much? Answer is never. Because the pain, symptoms of the infection never happens within first 48 hours. Most of the 48 hours or first 24 hours pain is because of the tissue reactions. So because you have done some procedures, same thing is applicable for the surgeon also, surgery also. Any surgery, the post-surgical infection never sets up within 24 hours. So within 24 hours, any increase of the pain and other symptoms, sometimes patient might be febrile also. That fever is not because of the infection. That fever is again because of the tissue reaction. So if you are planning to give some antibiotic, it's fine. But don't give antibiotic within the 24 hours or 48 hours if somebody is having the fever or increase of the pain. Always remember that is not because of the infection. That is because of the tissue reactions. So routine antibiotic prophylaxis is not done in majority procedures, but normally in our hospital, our protocol is when you are doing a disc procedure, when you are doing some more invasive procedures like gastric ganglion, joint injection, normally we give a short course of antibiotic before the procedure. Post-procedure prophylactic antibiotic we give only for the disc and gastric ganglion. For any other procedures, we don't give any other the post-procedure antibiotic prophylaxis. But it again depends on person to person, hospital to hospital, so protocol might be different. But if you are maintaining all those aseptic precaution, because infection is one of the very important thing, so you have to take care of all asepsis during any of the procedures. Even simple joint injection also, you should be maintaining all aseptic precautions. And that is the reason why it should not be done in an outdoor setup. It should be done in an OT setup, and all the sterile procedures, protocols must be maintained. So infection normally becomes symptomatic only after few days. So most of these patients will be presenting with a new type of pain, which was not there earlier. And other things, you have to do the blood test, you have to do the other things and to assess for the infection, which is rare for the interventions, but still it is possible, and that is the reason prevention of infection is more important than the treatment of infection. So these are in general the safety aspect and which are common for all interventional procedures. Okay?